Welcome. For today, we have Dr. Chris Thompson, Director of Endoscopy at the Brigham and Women's, Associate Professor at Harvard Medical School. Welcome, Chris. We're here to talk about duodenal mucosal resurfacing, proof of concept, procedural development, and initial implementation in the clinical setting. Chris, tell us about the history of how this came about and who thought about this and the rationale.
Sure. So, historically, diabetes it's a complex condition, and the role of the gut has come in and out of favor, historically, and there's foregut and hindgut theories tied to obesity as well as metabolic conditions such as diabetes, and in particular, duodenal mucosal resurfacing is sort of focusing on foregut mechanisms, if you will. Broadly, hindgut mechanisms were thought to be very tied to GLP-1. So they used to call it ileal brake and things like that, where bile or food will make its way down to the ileum, and the L cells will secrete a bunch of GLP-1. And GLP-1 does a lot of great things, right? It reduces insulin resistance, it increases insulin production, it slows gastric emptying, it crosses the blood-brain barrier, it tells you you're full. So GLP-1 does a lot of great things. So that's more hindgut. Foregut, by the way, GLP-1 is considered to be an incretin, right? So there's a family of these hormones that are thought to do this. The foregut is thought to have anti-incretins, right? And this is very theoretical, of course. There's more to it than that. In general, this would protect against hypoglycemia, say, right? And there's other things going on there, GIP, and there's other hormonal signaling that's thought to be tied to the duodenum. So in particular, the theory we were operating on is that the duodenum is not completely healthy in type 2 diabetes, and that might be due to leaky gut, it might be due to thickened duodenum is not functioning well, and it's kind of roughly based on this foregut hypothesis.
Very good. And what brought about this? Can you tell us about the device that you used for this study?
Sure. So there's this paper has several different studies within it, and the original work was done in a rat model. So it was Goto-Kakizaki rats, which have insulin resistance. And so it was not really similar to the device we're using in humans currently. But that procedure was done by laparotomy and gastrotomy, and then it was a balloon-based abrasion device. And so the rats were randomized into two groups, and one had the actual procedure where the balloon was inflated and duodenal abrasion was performed, and then the other group was a sham control where the balloon was just inflated, but there was no abrasion performed. And then after a 12-hour fast, a glucose tolerance test was performed. And we did see that there was substantial improvement in hyperglycemia in the treatment group compared to the control group.
Very good.
So that was encouraging. That gave us an efficacy signal and said it was worth pursuing further.
Mm-hmm. Very good. And what made you choose, for example, regular radiofrequency ablation versus just duodenal abrasion, or what was the thinking behind that?
So that was pretty complicated. So I think that the company that is involved in this did look at a variety of different methods of ablation, and they looked at steam, they looked at RFA, and they ended up settling on, with the current devices, actually hydrothermal ablation. So it's like a hot water balloon, actually, and they felt that was the most consistent way of ablating the mucosa, especially in the small bowel. So that actually was then tested out in the next phase of the paper, which was the large animal model, which was a porcine model. So we studied 15 pigs, and we're modifying the device and adjusting it such that you would have adequate ablation without damaging the muscularis propria. And so in those animals, it was noted once you'd harvest the duodenum that we were getting a pretty fairly consistent ablation of the mucosa without damaging that muscularis propria, and that was what we were going for. It was mostly a safety study, making sure the animals did not get pancreatitis or have other issues.
Right. So did you want to tell the audience about the results for each phase of the study?
Well, so with the rodents, we found out we had an efficacy signal, and we were happy with that, with lower hyperglycemia, on glucose tolerance testing. In the large animal study, we were looking for safety. We did not use, really can't study insulin resistance. It's more complicated in pigs. So we were looking more for safety and trying to get closer to a device that we could use in humans. Now, pigs certainly have different anatomy than humans. The muscularis propria is actually quite thin, so you design things with that in mind. But that was more of a safety study and feasibility to see that you could actually do this hydrothermal ablation with the system. And the system is rather sophisticated. It has little channels now on the outside of the balloon, and when you insufflate the balloon, the channels come in contact with the mucosa, and then you aspirate the tissue into the channels, and then small needles are placed into the tissue, and you inject a submucosal cushion of fluid. And that provides a layer of insulation and protection, again, so that you don't get a transmural burn. And then the water is heated in that balloon, okay, and you ablate the mucosa in that way. So we think that's a very safe way of ablating the mucosa, and it also provides a very consistent ablation. So that was what we ended up with all that pig work, kind of finally designing. And then the company has refined that and made that much more of an efficient process. Mm-hmm. And then, of course, they moved into the first in-human study.
Right. So how was the experience in the first in-human study?
So that was done in South America. Didn't do those personally myself. A great team down there, a clinical team performed those. And we did much of the cadaver work leading up to it and helped train the group. They had great success with the study. So again, we were looking primarily at safety, but we were looking for some efficacy signals as well. And they studied 29 patients that received the ablation. And what they found was that it was safe, which is good. Now, there were some issues with the early system that have been since modified, but the time between when you'd instill fluid into the submucosal space and then perform the ablation sometimes was rather prolonged. So we think we didn't have the full cushion in place for all of those ablations, and I think that was what led to the major complication we had was 3 stenoses, and those were all easily treated with a balloon dilation, but also something we wish to avoid. So with modifications, we think that's going to be less of a problem. But all in all, very safe. No pancreatitis or anything else that would be, very concerning. No perforations in the series down there. And efficacy signal was also there with over a point drop in A1C. And if you looked at people on stable background medicines, they were about a 1.8 drop in A1C. So clearly there's a good efficacy signal as well.
So what I found interesting was at 3 months, the repeat biopsy showed no more fibrosis and complete healing. And there was still a decrease in hemoglobin A1C. So seems to me that it's beyond mechanical issues with absorption of glucose. But what do you think is the mechanism behind the durability of response?
That's a good question. I'm not sure that anyone really knows, but there's thought that we're resetting stem cells, and the duodenum, is considered to be in an unhealthy state in type 2 diabetes and obesity. As I mentioned before, it's thickened and it's not functioning as it should. So when you ablate it, it gives it a chance to kind of reset those stem cells and grow back, in a healthy way again, in someone on a good healthy diet. I think the short answer there is we're doing more research and looking into that.
Very good. Any more final words for our audience in terms of future directions?
Well, it's very exciting. They're now embarking on a randomized trial in the United States. So, and that's already kicked off. So several sites are active, and we're looking forward to seeing the results of those studies.
Very good. Thank you, Chris. Thank you very much.
Thank you.